Good morning.
Good morning, Duke.
I'm sorry to be a little late. I actually had the wrong time. Wonderful. All right, let me just get my presentation ready to go.
Okay, so ready for the last session, aortic surgery. You've managed almost 2 days now. You've got a great panel in front of you. If there's anything these guys don't know about aortic surgery, it probably isn't worth knowing. So thanks to CTSNet, who are partnering with us and live streaming this session today. So without further ado, I'm going to hand over to Professor Underwood, who's our chairman, and Professor Cameron, who's giving the first talk. Thank you.
Thanks, Aaron. I hope you can hear me. We'd like to thank the CTSNet for streaming this. That's a huge accolade for the Birmingham Review Course. So I think we're going to do this in 2 phases. In the first session, we're going to have 3 talks started by Duke. And then the second session, we're going to go into a case discussion. If you've got any questions at all, please put them in the chat to everybody. And there'll be some time at the end of all of the presentations so that we can maybe have some discussion. Same for the case presentations as well. So we're going to start Juki screen sharing the Aortopathies talk, and then we've got Debbie Harrington, who's going to be talking about indications, and then we're going to go back to Duke again, who's going to be giving the talk that I wished that I'd heard maybe 15 years ago on type A dissection in your first day as a consultant. So Duke, maybe we can ask you to start the session now that your technology is working okay.
Yes, thank you very much, Malcolm. And again, I want to thank everyone for the invitation to participate again in this meeting. This talk is on aortopathies. And as many of you know, I'm a great fan of Sir William Osler, probably the most notable physician in Western medicine, and the first professor of medicine at the Johns Hopkins Hospital, where I worked for 3 decades. And he has this wonderful quote: "There is no disease more conducive to clinical humility than aneurysm of the aorta." And I think this is still true today. What I'm sure he was addressing was the unpredictable nature of aortic disease, and all of us, I think, still have an appreciation for the truth in that. I recently learned another quote from Osler, which I think is also quite applicable. "The tragedies of life are largely arterial," and also that longevity is a vascular question. I draw inspiration from Osler every single day. I also want to just pause and thank the UK for their remarkable contributions to aortic surgery. It seems to me all of my aortic heroes are English. In the upper left corner, Hugh Bentall, shown there with his remarkable paper describing the Bentall procedure, arguably the first aortic root replacement. This 2-page paper in 1968 in the journal Thorax, which described in remarkable brevity an easy, reproducible, and safe operation to replace the aortic root. And then Sir Magdi Yacoub, who described a way to replace the aortic root, but preserving the aortic valve, which was then taken many steps forward by Tyrone David and others, but again, an original contribution from the UK. And although maybe a bit more controversial, the more recent contribution from Tal Goldsworthy, John Pepper, and Tom Treasure, the PAIRS procedure, personalized external aortic reinforcement, a paradigm shift of treating aortic disease by essentially wrapping it and externally supporting it to prevent further distension and rupture, which although I had some of my doubts early on, the more I've learned about it and seen the results, the more I think that there is validity to this. And I'm so happy that someone is exploring a truly novel way of dealing with aortic disease. But all of these contributions from the UK, and all of you in the audience are part of this legacy and continuing tradition in making advances in aortic disease. So aortopathies and the aneurysms that result from them account for about 1 or 2% of deaths in the Western world. It's the 15th leading cause of death in patients over 65. And in a nod to Osler's comment about its unpredictability, these are often clinically silent until a fatal rupture occurs. About 20% patients have an affected relative, and often they're hereditary, and they are usually transmitted as an autosomal dominant. I want to point out an interesting observation that was made some years ago, that ascending aortic disease and descending thoracic aortic disease are two very different entities. Above the ligamentum arteriosum, aneurysms tend to be smooth, non-calcified, and not related to the traditional risk factors of atherosclerosis. They rarely have debris or clot in them, and they tend to occur in younger patients. Distal to the ligamentum, the aneurysms take on a different characteristic. They're irregular, they're calcified, they're often highly atherosclerotic, full of debris and clot. And although they may pose the same risks of rupture, it's really a very different entity. And proximally, it's almost more a disorder of growth, and distally a disorder of degeneration. Interestingly, these parts of the aorta also have different embryologic origins. And in this animal model, the ascending aorta and arch and some of the proximal neck vessels, which are shown green in this stain, which highlights tissues of neural crest origin. And the descending aorta and left subclavian actually arise more from the mesoderm and are shown here in white. I also want to pause and mention to you an article which I encourage all of you to read. It's called Cellular and Molecular Mechanisms of Thoracic Aortic Aneurysms. It's written by El Hamamsi and Sir Magdi Yacoub about 10 years ago and appeared in Nature Reviews Cardiology. You know, every senior surgeon has one paper in the literature that was written by someone else that we deeply wish that we had written. This is the paper that I wish I had written. It is one of the most insightful and thoughtful treatises on aortic disease. And it takes us a step away from the thought that these are largely degenerative diseases, but rather much more of a dynamic one, and perhaps a problem of loss of regulation of the living aortic wall. It says, the aortic wall is a dynamic environment composed of cellular and extracellular components that have important regulatory functions that maintain homeostasis. And that it's the dysfunction of the cytoskeleton, the receptor and extracellular matrix complex that lead to structural and functional dysregulation. It also points out that transforming growth factor beta pathways are also important in this matrix regulation. And excessive and increased activity of the TGF pathway is almost a common denominator in most thoracic aortic aneurysms. They also are characterized by apoptosis and a disarray of vascular smooth muscle cells, fragmentation of elastin, and disordered matrix metalloproteinases. But do have a look at this article. I think it will change the way you think about aortic disease. It points out too that the lamellar unit is the functional unit of the aortic wall, of a vascular smooth muscle cell that sits within the extracellular matrix sandwiched between elastin layers. And as we start to understand the genetics of aortic disease, we appreciate that this functional unit is key to the development of some of these processes. Now, there are syndromic and non-syndromic forms of thoracic aortopathy, and we've learned a lot about the genetics and the pathophysiology of aneurysms from some of the syndromic ones, which were easy to identify in patients, like the Marfan syndrome patients who are tall and thin and have a particular skeletal build that is easily recognizable. But other syndromic features or diseases include the Loeys-Dietz syndrome, Ehlers-Danlos, even some patients with the bicuspid aortic valve syndrome, arterial tortuosity syndrome, and of course, Turner's and Noonan's. But there are many other non-syndromic, which are difficult to recognize phenotypically, and we're learning to recognize them more by their genetic profile. Most of the mutations that occur in these diseases affect either the fibrillin protein, the TGF-beta receptor, or the ACTA2 gene, the MyH11, or the Notch1 genes that control either valve tissue or the myocyte, or the TGF-beta pathway. Let's go through some of the more common ones just to touch on each of these. Marfan syndrome is the poster child for aortopathy. It's the most common inherited connective tissue disorder if you exclude bicuspid aortic valve. And the cardinal features are the skeletal ones, the ocular feature. In fact, a dislocated lens is the most common feature in Marfan syndrome. But the most important in terms of survival and overall health are these root aneurysms that can achieve very large diameters and then lead to ascending aortic rupture or dissection. And all of the premature mortality in Marfan syndrome is due to aortic catastrophe, virtually all of it. And on average, untreated, lifespan is shortened by a third. We've known since the 1990s that this is associated with a fibrillin mutation on chromosome 15, but only in the last 15 to 20 years have we appreciated that that fibrillin mutation actually has a greater impact, not on the structural integrity of the aorta, but rather on TGF-beta signaling. It leads to a very high excess of TGF-beta in the tissue, which leads to most of the morphologic features of Marfan syndrome, not just the aortic aneurysm. Similar, but actually quite different in most respects, is the Loeys-Dietz syndrome. This was a syndrome described in 2005. These patients had aortic root aneurysms very similar to Marfan syndrome patients, but in many reasons it behaves differently. And this is a result of the TGF-beta receptor mutation, which also leads to TGF-beta excess and leads to these aortic changes. Now, these patients have a very, very distinct phenotypic feature. There's hypertelorism, there's arterial tortuosity, which you rarely see actually in a non-dissected Marfan aorta. And up in the upper chest, the folding and the tortuosity can be absolutely astounding. They also had a bifid uvula, which is a near constant feature. Oh, and as I say, these are due to mutations of the TGF-beta receptors that lead to excess TGF-beta signaling. There are certain mutations within the Loeys-Dietz syndrome which are particularly malignant, and I think it's actually one of the best examples of where a specific mutation within a disease entity is changing the operative planning and overall approach. This particular mutation, the ARG528 HIS-CIS in the TGF-beta receptor, has led to the worst aortopathy that we have seen in any patient. We saw 19 of these patients at Hopkins, all required root surgery in early childhood, all needed a second surgery, usually for ascending aorta or subclavian aneurysms. No patients reached their third decade of life, and 1/3 have died in childhood during type B dissection. These patients need very extensive reconstructions of the aorta and the arch vessels. Bicuspid valve aortopathy, you are quite well aware of, and I'm not going to say a lot about it, but of course it's about 2% of the population, and half of the bicuspid aortic valve patients have a dilated aorta. Do they dilate because of the hemodynamic effect of the valve, or is it an intrinsic aortopathy? And this is a nature versus nurture debate that's been going on for decades. And if anything, the pendulum has swung a little bit back toward the hemodynamic argument that it is in fact the valve working on an abnormal aorta that leads to the aneurysms. It's interesting, if you look at the guidelines for bicuspid aortic valve aneurysms and when intervention should be offered over this period from 1998 to 2014, they're all over the map. The red is the threshold for surgery recommended by the various guideline committees. The red is for the ascending aorta with a normal valve, and the bottom is the red is if the valve is abnormal. The blue is if the bicuspid valve is functionally normal. Studies that looking at the flow dynamics in a bicuspid aortic valve show that the pattern of fusion of the leaflets actually has a big impact on the size of the aneurysm. So we're understanding now that the valve does have an impact on the aorta, and that even it affects the histology of the aortic wall. There are other conditions where aortopathies exist, certain congenital heart defects, the conal truncal defects, hypoplastic left heart syndrome, coarctation, all have an abnormal conotruncal predisposition to dilatation. Turner syndrome, Ehlers-Danlos, Noonan's, the familial thoracic aortic aneurysms all have predispositions to dilatation. The genetics of this are interesting. They're quite heterogeneous, and it's difficult for me to summarize this. These are the genes that tend to affect at least the non-syndromic ones, and the inheritance, interestingly, is almost always dominant.
Duke, sorry, can I just interrupt you for one moment? Your slides are stuck. On Zoom.
How do I get rid of it?
The last slide we've got is Marfan's. I don't know whether if you've tried coming in and out of your presentation.
Well, thanks for letting me know. Let me just see. All right, I'm going to stop sharing and then come right back. Is that what you're asking or recommending?
Yes,
Yeah,
yes,
good
please.
idea. Stop sharing, come back.
Sorry, that's a new problem for me. Are we back?
We are back. Very good.
I think this was just a ploy to get me to stop. So go on. Here is the role of genetic testing. Let me see if I did miss a slide here. Here, so John Eleftheriadis has classified all of the genes that have been identified and associated with thoracic aortic aneurysm. You're not supposed to be able to read all of these, but there have been about 29 genes identified, and most of them do, as I mentioned earlier, they involve coding for the extracellular matrix or smooth muscle cell contraction or TGF-beta signaling, and are usually autosomal dominant. And remember that about a quarter of thoracic aortic aneurysm patients have an affected relative. What's the role of genetic testing? Well, it will confirm the diagnosis in a phenotypically ambiguous patient. It may be able to identify specific mutations, such as I showed you in the Loeys-Dietz patient, and predict risk, particularly in non-syndromic patients. It will help with planning, and again, in that Loeys-Dietz patient, it can actually lead to a personalized treatment for their surgical resection, specifically the timing and the extent of the resection. Genetic testing is now commercially available. This slide is a couple of years old, and I think a panel back then was about $2,000, $3,000, and I think that cost has come down quite a bit. So in conclusion, bicuspid aortic valve is probably the most common aortopathy, but it is a less severe aortopathy than most that we've talked about today. The phenotypically obvious syndromes, such as Marfan syndrome and Loeys-Dietz, have some of the most aggressive aortopathies. The threshold for intervention and the extent of intervention or resection is disease specific, and there really wasn't enough time to go over those in great detail. Remember that about 1/5 of thoracic aortic aneurysm patients will have an affected relative, and that congenital heart disease patients in particular, and those with conotruncal abnormalities the most, are prone to ascending aortic dilatation. we really don't know the thresholds that we should be employing for operating on these patients. And that it's the mutations in the TGF-beta pathway and the vascular smooth muscle that lead to most of these aneurysms. Genetic analysis does hold great promise in the assessment of risk and tailoring care, as well as even non-surgical therapies, as we better understand why the aortic wall comes undone. I look forward to questions, and again, thank you for the invitation to share this information with you.
Duke, thank you so much. Again, such a concise presentation on a very, very complex topic. I was just wondering if I could take you back to the pairs procedure, because I think that within all of your presentation, that might be one of the most innovative things that we've got in our armamentarium. And like you, I was very skeptical about this until I saw Tom Treasure, who you know was involved in the science of all of this with John Pepper, at a meeting in Milan, and he was showing me the histology slides of a Marfan patient who'd had this treatment, who died in a car accident just incidentally and had a post-mortem. And the histology had sort of showed that there was a complete regression of the abnormalities that you've described associated with the genetic thing. So really, I think for the audience, what maybe do you think might be the mechanism that this is protective?
Well, it's good to hear you describe your reaction to it and your thought processes. They're exactly mine. I was skeptical because you know, we had tried aortic wrapping a long time ago, and it didn't work. It was usually in other parts of the aorta, and it was a different graft material too. And there is something different here, and the graft becomes integrated into the aortic wall, and it changes the aortic wall, and in a way that is supported by that paper by Sir Magdi, that the aortic wall is dynamic and that it can even reverse some of its properties with time. But the general idea that a well-crafted, tailored graft, which becomes integrated into the aortic wall, can prevent further dilatation and dissection, which is supported by their 1,000 patient year follow-up. Now, you know, over 300 patients, I think makes us rethink what can be done. And you know, there are a lot of applications here. First of all, you know, they do tend to put these on at a little bit earlier stage of the disease, so that they're reinforcing roots before there's a lot of valve damage and aortic regurgitation. You can imagine if you were operating on the mitral valve in a Marfan patient and his root was perhaps only 4, putting this external support on it at the time of the mitral would make great sense and would save them an operation later on. There are lots of other situations in adult congenital heart disease where early reinforcement of structures that are dilating progressively will have great appeal. So I really, I've come full circle on this, and I really think that this is innovative. It's bold. They've approached this very scientifically, kept very good records, and withstood a lot of criticism. You know, when surgeons have a solution in their hands already that works pretty well, they're very reluctant to give up those therapies and move on. But this group has really forced a lot of us to think differently about aortic disease. It's a paradigm shift.
Yeah, no, thank you very much for that answer. And I suppose for the audience, it would be interesting for you to know that the person that's behind all of this is actually an engineer who had a problem, and he wanted to design a solution for himself. And this is what he came up with. We've got one other question down here from Dr. Kundan. I'm going to try and paraphrase it, but essentially, I think what he's asking is that in patients that have a syndromic problem, can they dissect at any size, or is size still an indicator for the risk of dissection?
The short answer is size is still an indicator. And we use size in almost every patient, but the threshold is what varies according to the genetic diagnosis. And the best example is Loeys-Dietz syndrome. If it was very early on that we appreciated that dissection and rupture occur at much lower diameters than, say, Marfan syndrome, and that the threshold for intervention should probably be closer to 3 centimeters in children and maybe 4 in most adults with Loeys-Dietz. That it just behaves differently. But if you've got a 5 centimeter Loeys-Dietz aneurysm, you're more likely to rupture that than a 3 centimeter in the same person. So size still matters, but the threshold varies.
Okay, super. Duke, thanks very much indeed. I know we're going to come back to you for another talk. You know how the Birmingham Review likes to work you as hard as they possibly can. But I think we should move on. And I think we've got Debbie Harrington here. Are you here, Debs?
Yes, I'm here.
Hi.
Hello,
so
hi.
Indications.
Good evening.
Good evening. Good morning.
Now I'm going to try and share my screen. Yeah, here we go. Hopefully this will work. Okay, can people see that?
Yes, it's working. Fantastic.
Okay, good. Okay, so I'd like to thank the organisers for asking me to speak on the indications for intervention on the thoracic aorta, and it's quite a lot to talk about in 15 minutes, so I'm going to sort of whiz through it all. So excuse me if I'm brief. I have no disclosures to make, so I'm going to try and cover the following areas. So I'm going to talk about asymptomatic aneurysm, which starts with the root and ascending aorta and the arch, and then talk a bit about the descending thoracic aorta and thoracoabdominal aorta. I'm going to mention some special populations and talk a little bit about acute aortic syndromes, and then finally just a quick mention of traumatic injury. So most of our practice worldwide is based upon these 2 sets of guidelines. So the American Heart Association guidelines, which were published in 2010 in Circulation, and the European guidelines published a few years later in the European Heart Journal in 2014. And our daily practice is still based upon these guidelines, as is much of this talk. So I'm going to start with asymptomatic ascending aortic aneurysm. So this includes aortic root as well as ascending aorta. So the American guidelines state that there is a class 1 indication. So in other words, people should have surgery, should have intervention with a dimension of 5.5 centimeters or greater. So this is our probably the majority of our patients. So this includes aneurysm, chronic dissection, intramural hematoma, penetrating ulcer, and pseudoaneurysm. Then, as Professor Cameron's already alluded to, patients with Marfan's or other genetically mediated conditions, and also in some instances bicuspid, we'll talk about that in more detail because it's a bit more complicated, as he's alluded to. These patients should undergo surgery at lower dimensions, so between 4 and 5 centimeters, and we will talk more about that. Another indication is growth rate of more than 0.5 centimeter per year. And also, we all know that patients undergoing concomitant surgery, so other cardiac surgery, if they have a dilated ascending aortal root, they should, as long as they haven't got too much comorbidity, have intervention at about 4.5 centimeters, and that would be quite a common day-to-day sort of intervention. Now then, it is reasonable to perform intervention for genetic diseases, aortopathies, Marfan syndrome, some bicuspids, if the patient has an aneurysm with a ratio of maximal area in square centimetres divided by the height of the patient in metres more than 10. So this kind of alludes to people with a small stature. So for example, women with Turner's syndrome, for example, or some familial aortopathies where you've got a patient with small stature and a relatively big aorta. As we've already heard, patients with Loeys Dietz and certain confirmed genetic mutations should undergo surgery at a much lower dimension. 4.4 to 4.6 is in the American Heart Guidelines, and that's on external diameter on cross-sectional imaging, or 4.2 centimetres on TOE. So there are some other considerations as well. Patients who have symptomatic aneurysms, so in other words, symptoms suggestive such as pain, suggestive of expansion, should undergo prompt intervention, whatever their aneurysm size. Patients who have minimal root dilatation but have an ascending aortic aneurysm should undergo separate valve and ascending aortic replacement. And this would especially be true in perhaps elderly patients, as we know that reimplantation of the coronaries does carry some extra risk. Patients who have dilated roots and dilated sinuses of Valsalva, especially those with an aortopathy, such as Marfans or Loeys Dietz, should undergo modified David reimplantation if feasible, or a root replacement with a valve graft conduit. Now it is moving on to arch. So it is reasonable to perform total arch replacement when the diameter exceeds 5.5 centimetres. And aneurysms, including the proximal arch, it is reasonable to undertake partial arch replacement with an ascending aortic replacement. It is also reasonable to perform total arch replacement in patients that have a distal arch aneurysm or proximal DTA aneurysm, and usually this would be with an elephant trunk. Often these days we would use a frozen elephant trunk either as a single procedure or as a first stage with a planned second stage, which is often these days endovascular but could be open. And if we look at the European guidelines, they agree that there is a class 1 indication for surgery in patients with Marfan syndrome at 50 millimetres, so 5 centimetres. Patients with additional risk factors, it is reasonable to operate with Marfan's patients at 45 millimetres and with bicuspid patients at 50 millimetres. Patients with no additional risk factors and no aortopathy, it's reasonable to continue with the 55 millimetre threshold. And so we're just going to talk a bit about what these additional risk factors are. So things to, we've already mentioned body surface area in patients of small stature, and we've also mentioned rapid progression and also concomitant surgery. Other potential reasons for lower threshold would be a strong family history. And I think that's a very important thing to consider. Patients that have a strong family history of dissection, especially in first degree relatives at a young age, should be considered for early surgery. And also the patient's own preference is mentioned here, and I think that's an important consideration as well. Patients, some patients, young patients with an aneurysm that may not be that big, but some of them just don't like the idea of having an aneurysm and would rather have it removed. Whereas you may get some patients who really don't like the idea of an operation and are quite happy to live with their aneurysm. The European guidelines also agree that arch aneurysms should be operated on at 55 millimetres, and that's also reasonable in patients undergoing surgery for an adjacent segment of the aorta. Just to focus a bit more on the question of bicuspid aortopathy. So there has been some confusion here and some discrepancies in the guidelines over the years. So the European guidelines, remember this is 2014, say that in bicuspid patients, surgery of the ascending is indicated if the root or ascending are more than 55 millimetres, so that's a class 1 indication, or if the root or ascending are over 50 millimetres in the presence of other risk factors. Now, this was explored further because clearly there have been some discrepancies in the guidelines. This was clarified in a paper published in 2016 in the JTCVS by the American College of Cardiology and American Heart Association. And now they have come up with a consensus recommendation, and this has been due to some conflicting evidence and a lack of sufficient trials. But there is some evidence that bicuspid patients actually dissect at a higher dimension than tricuspid patients, or patients with a tricuspid valve. And therefore, the consensus is that operative intervention in the asymptomatic patient with bicuspid valve disease with no additional risk factors should be at 5.5 centimetres. However, it is reasonable to intervene earlier, in other words, at 5 centimetres, in the presence of additional risk factors. So ones we've already mentioned, family history, growth rate, but also uncontrolled hypertension. And also to be taken into consideration is the surgical risk of the patient, and also the experience of the operating surgical team and centres with established expertise. It's reasonable to perform surgery at a lower dimension. So moving on to talk a bit about descending and thoracoabdominal aneurysms. So again, in asymptomatic aneurysm, so this is talking about the descending thoracic aorta now. So isolated descending thoracic aorta, patients with chronic dissection, and especially those with connective tissue disorder without comorbidity, should undergo open repair at 5.5 centimetres, according to the American guidelines. Patients who have degenerative aneurysm or traumatic saccular aneurysms or pseudoaneurysms are recommended to have endovascular intervention if feasible. And in thoracoabdominal surgery, so when the aneurysm extends below the diaphragm, we know that these patients are subject to a higher risk with surgery of both mortality and morbidity, and therefore surgery is recommended at a higher dimension of 6 centimetres, unless, of course, the patient has a connective tissue disease, such as Marfan or Loeys-Dietz, when the threshold would be significantly smaller. The European guidelines consider that TEVAR should be considered rather than surgery if possible, and they suggest that if open surgery is to be performed in the descending aorta, that the threshold should be 6 centimetres, but agree that in the case of syndromes and aortopathies, open surgery should be indicated rather than endovascular means. I'm just going to move on and briefly talk about acute aortic syndromes. And there's widespread agreement. We all know that patients with dissection really should be undergo surgical consultation, and that is for regardless of anatomic location. Dissection of the ascending aorta, so type A dissection, should be urgently evaluated for emergency repair. So the American guidelines, remember this is from 2010, suggest that descending aortic, i.e. type B dissections, should be managed medically unless there are complications. With intramural hematoma, it is reasonable to treat this as a dissection in the corresponding segment. So in other words, if you have a type A intramural hematoma, it is entirely reasonable to treat this as if it was a type A dissection. And we would normally do this as long as the patient is fit for an operation. Just looking at indications for TEVAR from the American heart guidelines. So as we all know, complicated acute type B dissection is a class 1 indication for intervention with endovascular means. It's also reasonable to treat patients with type B penetrating ulcer and IMH with TEVAR. Now, they have suggested that non-complicated type B dissection, i.e. patients with no ischemia, may be considered, so that's a type 2B, a class 2B indication, may be considered for endovascular intervention. Now, this has been updated somewhat. The European guidelines, published a little bit later, were take into account some of the more recent evidence, and the INSTEAD trial, for example, did publish 5-year results showing improved outcomes with TEVAR in uncomplicated type B dissection at 5 years. And so this, the European guidance does actually reflect this, with endovascular intervention being a class 2A recommendation with level B evidence. Now I'm just going to mention this entity. So the non-A, non-B dissection. which was nicely described in this paper published last year in the European Journal. And this was a good paper looking at all sorts of aortic arch pathologies and gave an expert consensus opinion. And it describes non-A, non-B dissection as a new entity really, and a different separate entity from type A and type B. So these are arch dissections that are proximal, involve the arch proximal to the left subclavian, but distal to the innominate artery. And they have been shown to have a worse prognosis than your standard uncomplicated type B dissection, but possibly not quite so bad as the type A dissection. And so the suggestion is that they are sort of managed as an independent group, and that certainly the threshold for intervention should be lower than it is with the type B dissection. Now, just finally, just to mention, trauma indications for intervention are now, all of the guidelines are have a consensus really that endovascular intervention is the best treatment for trauma. So in summary, we've just looked at a brief run through all the indications for intervention of the segments of the thoracic aorta for asymptomatic aneurysm. We've talked about some of the special considerations, mentioned briefly acute aortic syndrome, and just before running out of time, trauma. So I'd like to thank the organisers once again and ask if there are any questions.
Debs, thank you very much indeed. There's some questions coming in on the chat. There's one question from me that I'll bring up, and then there's a separate question that's coming in the chat that I might involve Duke in as well.
Okay.
So the first question from me is that we talk about size in aneurysms per se. Can we apply that to chronic dissections? Because a lot of the time, that's what we're talking about in terms of chronic dissections. And to give you time to think about that, because I'm such a kind and generous person, I'm going to also put forward the second question. The second question that's been coming forward that Duke might have some impact on is, should we not be indexing all of these size? Or, you know, what's the value of the Z score in Marfan syndrome? So maybe let's go with the first one. What are your thoughts, Debs, on, you know, the chronic dissection? Because that's a lot of the patients that we see with what the referring physicians call, you know, an aneurysm. It's a chronic dissection that's got big. Can we use the same data?
So are you, I'm assuming you're talking about descending and thoracoabdominal in this situation? Yeah. I mean, I think so. Yeah, we certainly would. Again, it depends on whether they are a syndromic patient. Really, I think that's what the key is. Certainly, with our thoracoabdominal aortas, we use 6 centimeters as in a patient with no aortopathy. We would use 6 centimeters as a threshold for intervention, but it is, you know, it has to be personalized, I think, depending on the individual patient. So for example, a lot of our patients now are syndromic. Actually, a lot of these patients may not have a genetic diagnosis, but actually they have a family history of dissection, and I think we worry about those patients more. We also have patients who rapidly expand, and again, there's lots of things we don't know, I think, about the behavior of the aorta in after patients have had a type A repair, for example. Some patients rapidly expand their descending thoracic aorta, and some patients don't expand it, and we don't really know why that is. But again, those that rapidly expand, I think we would intervene sooner rather than later. I don't know, does that answer the question?
Yeah, it has. I think I struggle with this because we see a lot of patients that have got residual descending dissection, type A repair, you know, and like you say, some of them expand quite rapidly, but some of them can stay at, you know, a 6 centimeter descending for years, and they don't expand. So I think what I'm trying to say is that, you know, are there some other markers that we can use to try and risk stratify those groups that might be at risk of a really bad complication from that? And I'm just not sure that translating the literature from an aneurysm to a chronic dissection is necessarily true. There was a recent paper from Japan, I think probably 18 months ago, that actually suggested that the figure should be lower. But with the difference in pathology, I'm just wondering whether we should be looking for other things that will help us decide in those patients, i.e., you know, a small true lumen or something like that.
I think we certainly worry about the partially thrombosed false lumens. I think we worry about that as a risk factor. And certainly, I think you're right about the small true lumen. Yes, definitely. And also those patients that have pain as well. I think that's a bad prognostic sign.
Yeah. Great stuff. So I'm going to bring Duke in now because we've got a lot of questions about indexing. Should we just be indexing this rather than absolute size? So what if you've got a 40 kilogram Marfan's patient with a 5 centimeter aorta? Is that the same as a 70 kilogram person with a 5 centimeter aorta?
Oh, this is a decades old argument, and I'm not going to have an answer for you today. People have said, well, it's intuitively obvious that it matters whether it's a 40 kilogram woman or a 120 kilogram man. And others say, well, the aorta doesn't know what the host size is. Yeah. These are properties of the aorta. I don't know the answer to this. I think if I have to make a guess, sure, it makes a difference, but I'm not sure it makes a big difference. And whether it's worth normalizing for body surface area, or even if body surface area is the right parameter to index by, I mean, that's a whole other question. Some people have said it's height, not BSA. But I don't know the answer. And as to that issue about the chronic dissections and whether we should be using the same criteria, I think that you know, the Laplace formula I think still holds, and that in many of these dissections the wall is thinner, and that for that reason I would predict that the same rules should apply, and maybe even more so. But as Debbie pointed out, it also has to do with whether the false channel is thrombosed or not, what's going on in the true channel. But this is something that deserves study. It took us decades, though, to generate these risk curves for aortas and their risk of rupture when they're not dissected. It'll be a real challenge to do it in the dissecting. I think rate of change would be my suggestion as the most important parameter.
Yeah, no, that's really interesting, and thanks for that talk and the comments, Duke. So I think for the participants that the message from all of that is that really we're still individualizing all of these decisions based on multiple factors, and you can't just take, you know, one guideline and plonk it on one patient. You've got to really try and individualize the decision. Okay, so Duke, if you don't mind, we're going to move on to your second talk. Like I say, the one that I hoped 20 years ago that someone would have given me about coping with a type A dissection when you're a day one consultant. And I think that at the end of this talk, we'll bring in quite a lot of questions that have come up within the chat as we've been going through Deb's talk on classification of, you know, non-A, non-B dissections, etc. So Duke, thank you very much.
Well, I too wish I had heard this talk when I started. I'm not sure everything that I say is true, but it's been my experience in 35 years now that most of what I said is I think true. Let me also put out an offer. There is a two-issue set of or a dedicated issue in 2 volumes from the Annals of Cardiothoracic Surgery that I edited along with Joel Price, who is now in Vancouver, but was on our faculty at Hopkins for a number of years. And these are a series of invited expert articles on a broad range of subjects related to type A aortic dissection. And I was really proud of this collection, and it's quite large. And if you would email me at my work address there, and just put BRC 2020 in the subject line, I'll email you the Dropbox link, and you can download this whole series of articles. It's a 20 megabyte file, so it'll take a little while. But I think this is an online journal, by the way, I mean, as well as paper. And you can go in and do this yourself, but you'll have to download each of them individually. It'll take a lot longer. But just email me, put BRC 2020 in the subject line, and you'll get all of these articles, which I think you will enjoy reading. All of you know that acute type A aortic dissection is a real calamity. About 20% of patients, we believe, never make it to the hospital. And those who make it to the hospital but are not attended to surgically, about half of them will die in the first 48 hours. What bothers me is that people have linearized that risk and said that it's 1 to 2% per hour, but that's not true. It's not a linear function. If you look at these curves up here, it is quite different. There's higher risk in the first few hours and a lot less later on. So try not to use that 1 to 2% per hour mortality risk for important decisions, because it's really not a linear function. But what's pretty clear is that if you have a type A aortic dissection, if you have an operation, you're twice as likely to be alive a month later. And we clearly have a tremendous impact on this disease. So this is a very basic talk, but let me just share with you some of the things that I think are important and basic principles of taking care of these patients. It's really important to see these patients in the emergency department or in the ICU before you operate on them. It's good to know about their onset and their quality of pain, whether they had hypertension, whether they knew they had an aneurysm, and very importantly, whether there's a family history. The physical exam is still important here, as important as CT scans are. You got to know what the pulses are in the extremities. What's their blood pressure? Are they tachycardic? Are the neck veins distended? Do they have acrocyanosis? Is there a murmur of aortic regurgitation? Is the abdomen tender? The investigations that we rely on are the EKG to look for signs of coronary ischemia. The chest film is pretty nonspecific, but it will alert you to blood in the mediastinum or pleural blood. The CT scan, if you only had one test to order, a CT scan gives the highest yield. It shows the intimal flap, the extent of it, hematoma along the course of the aorta, and can even give you an idea about radiologic malperfusion if you see the contrast not appearing in the branch vessels. An echocardiogram is mainly to assess the LV function and to detect whether there's aortic regurgitation present. Most of these patients do not and should not have an invasive coronary angiogram because of the risk of the tip of the catheter creating misery. And an MR just involves moving to another part of the hospital where the patient is not well monitored, and there's not likely that you'll get important information that wasn't obtained from the CT scan. The CT, as I said, will show the intimal flap and the distal extent of it, give you some idea about reperfusion. And the echo tells mainly about valve function and ventricular function, but it may give some additional perspective on the intimal flap. But these are the two most important of the imaging studies to get. Papers years ago used to stress TEE, but it always frightened me to sedate a patient with an acute type A and try to put a TE probe down and have them gagging and coughing and such. And it's really best done, in my view, in the operating room when they're asleep, where it can be done less traumatically. There is important preoperative management. Once the diagnosis is made, you've had your discussion with the patients, I think it's important for them to be sedated. Anti-impulse and antihypertensive therapy is important, but be careful about using vasodilators alone, because that can actually increase the impulse forces and put more stress on the disrupted aorta. It's a combination of beta blocker and vasodilator is probably optimal. Arterial monitoring with an art line is important, and some of these patients need a careful volume resuscitation rather than going to the operating room markedly hypovolemic and unstable. And many of these things can be done before the patient actually gets to your specific hospital. At areas of our country where regional care for dissections is well organized, all of these treatments are begun before the patient's even transferred. And well-organized programs, such as the one in Michigan, have seen great benefits from this kind of integrated approach. Now, once in the operating room, I think it's important to have bilateral radial artery lines and one femoral artery line. Even if there's a good pulse to begin with, that can change after the operation, and knowing what the pressure is at the femoral arteries with a monitoring catheter is valuable. They need at least a central venous line, perhaps a pulmonary artery catheter, and NIRS monitoring, cerebral oximetry. The entire perfusion and surgical team should be standing by and ready, because the induction of anesthesia will sometimes precipitate hemodynamic collapse. And it is your responsibility to develop a plan for the resuscitation or the institution of urgent bypass if the patient decompensates. And it should be a very specific plan that's discussed and understood by all members of the team. Hoping for the best is not a plan. And the TEE, as I say, should be done, I think, after induction. Now, at risk of sounding like I'm editorializing, and I know some people feel differently about this, but these are patients that I think more than any other cardiac patient that I can imagine should be cared for in a quiet and focused operating room. No music, no chatter about things irrelevant to the patient or the patient's operation. And I know some people feel very strongly about music, but music is noise to the person who's not actually listening to the music. And I've always found it interesting that when there's a major calamity in the operating room and there's music playing, the first thing that people do is turn the music off. What does that tell you about music? And by the way, I love music, and I have it on almost everywhere else in my life. But I really don't think it belongs in an operating room, especially where an operation which has a 20% operative mortality is going on. Another thing that I've learned in my experience is that if you have complicated operations, particularly when there are multiple steps in the algorithm, which could go either way, I think it's important for the surgeon to write out all of the steps in the operation, commit them to paper, and think about it. And even draw the algorithm yourself. It will help crystallize your plan so that when you get into the operating room and in the heat of battle, you know what the steps are. Cannulation. This is really about arterial cannulation, and there has been an argument still going on 2 decades later about whether it makes a difference to cannulate the femoral artery or the axillary artery or even central arteries. And it's actually been difficult to show an advantage of the femoral or axillary over one another. But I think we can all agree that the simplest and quickest way to get somebody on bypass is with the femoral artery. If the dissection comes all the way down to the inguinal ligament, it's probably better to do it open so that you know for sure which lumen you're cannulating. If you're doing an axillary, then it's usually with an 8mm Dacron graft, and it's good not to fully heparinize until you've secured that graft to make sure that it's hemostatic. Some people will cannulate the artery directly, but if the dissection involves the innominate artery, probably best to do it open, again, to be sure you know where you're cannulating. It is possible to sew a graft onto the innominate artery or even cannulate the innominate artery directly. But again, you have to be sure that the dissection does not involve that local area. And I use this a lot when I'm just using the innominate artery for selective cerebral perfusion. It's a lot easier to just cannulate that artery with a small pediatric 14 French cannula and perfuse the head while you're doing the arch work. And a lot quicker, as I say, than dissecting out the axillary. There is enthusiasm for direct cannulation of the undersurface of the arch, and I have no experience with this, but some people are very enthusiastic about this, but I think this requires some experience, and it often needs some guidance with imaging. So unless you're experienced with this, and this is truly your first day and your first dissection, I would go with perhaps some of the more straightforward and well-established techniques. There are also ways to cannulate through the LV apex or even transect the aorta and cannulate it directly if you're really in the middle of complete collapse, but I won't go into those. When you initiate cardiopulmonary bypass, do it gradually. Don't take all the volume off the patient and then bring the flow up. Start the flow at a low level and bring it up and watch the pressures in the leg and the two radial arteries, because a patient who may not have perfusion before, when his heart is pumping blood antegrade, may develop malperfusion as you start to retrograde perfuse. Even when you're perfusing the axillary artery, the pattern of perfusion may change. So go on gradually. And if there's a large pericardial effusion or tamponade, consider being on bypass before you even make the sternotomy. You should not cool until the heart is empty and you're either ready to clamp the aorta or have a good LV vent in place. And another point I want to make about LV venting, if you have severe aortic regurgitation, truly severe, no vent is going to keep the heart completely decompressed. And also, even if it did, if there's that much regurgitation, then all of the blood from the perfusate of the heart-lung machine is going to come back through that LV vent, and you're going to be systemically hypoperfused. So don't kid yourself about LV venting. It's fine for mild to moderate regurgitation, but it really will not be the solution to the problem if you have severe. The degree of cooling is surgeon's choice, but I think most would still cool to the mid-20s or upper 20s if you're going to use selective antegrade cerebral perfusion. But if you're going for hypothermic circulatory arrest to deal with the distal end of the graft or the arch, then it's probably better to be colder. Now, retrograde or antegrade, that's controversial too. I'm actually not even a big fan of retrograde. I'm in the minority, but remember how often the right coronary is compromised a little bit in dissections, and that will be a problem for both antegrade or retrograde. If you have a problem, by the way, with a nearly occluded right coronary artery, consider either opening the root very early and giving it antegrade, or even putting a bypass to the right coronary to make sure that you adequately protect the right side of the heart. Retrograde, as you know, doesn't work well to protect the whole right ventricle. So tailor your approach accordingly. Should you clamp the aorta in a type A? Well, again, controversial. Some people will almost never clamp it unless there's severe aortic regurgitation, and some will do it routinely. I think you can be selective about it. You obviously don't want to clamp an aorta if you know there's thrombus in the false lumen because of the risk of embolizing it. Maybe better not to clamp a calcified aorta, although heavy calcification is not common in type A dissections. With severe aortic regurgitation, you're going to need to clamp it to be able to arrest the heart and keep it decompressed during the cooling. So that'll be tilting the scales toward clamping. And in patients who've had cardiac operations before, it may be very difficult to get around the aorta. And in that situation too, you might not want to clamp, and you'll just hope that the aortic valve is competent. Once you've opened up the root, you need to assess, or I should say, when you've opened the ascending aorta, you need to assess the root and figure out if there are intimal tears or just dissections of the sinuses. It's a big difference, because if there are intimal tears, you'll probably need to replace the aortic root. I'll show you in a moment where you can make an exception there. You'll also want to assess the valve. If it's a highly stenotic bicuspid aortic valve, you'll at least need to think about replacing the aortic valve, but may or may not need to do the root. And if there are dissections extending into the coronaries and you have a coronary malperfusion, you're probably best to consider a root replacement and deal with those coronaries either with bypasses or direct repairs of those proximal coronary dissections. What's called valve resuspension is just displayed here. And of course, when there's dissection within the wall, the commissure of the aortic valve loses its support and it folds down into the base of the root and causes prolapse of the two leaflets here. And to restore valve competence requires resuspending at the appropriate height, the top of the commissure with a pledgeted stitch, pledget inside and outside the aorta to the adventitia and aortic wall. It also requires some judgment about what is the ideal sinotubular junction diameter here, because it may be a bit dilated. Maybe the patient had aortic regurgitation because of that before the dissection. So not only do you want to suspend and stabilize the commissures, but you want to choose a graft which gives you the optimal sinotubular junction diameter to promote leaflet apposition. And you'll also want to repair this dissection here because these two layers of tissue are now quite friable. And to sew the graft here, I think it's best actually to reinforce it with a strip on the inside, a strip on the outside, and even one in the middle if it's deeply dissected and you want to support it there too. I'll show this in a minute, but I do feel that that strip of felt on the inside is important because when these are closed primarily, there's a real tendency for the suture to tear through this inner layer of intima and part of the media. And that, of course, can lead to late dissection into the sinuses. Now, after the proximal part is done, while you've been cooling, you'll need to focus your attention to the distal anastomosis. Now, if it's a type 2 or DeBakey type 2 and the dissection doesn't extend beyond about this point here, you might be able to do the whole thing with the aortic clamp. But most of the time, 75% of the time, it's a dissection that goes all the way around, DeBakey 1. And whether you should resect an anastomose to here or extend out to here, I think is surgeon preference and to some extent what the dissection looks like and whether there might even be small tears here that could be excised. But once that graft is done, you can then restart the bypass again. It's really important that once you resume bypass after an open anastomosis like that the perfusion be antegrade. If you sew a graft in here that has a little sidearm, you can use that sidearm, or you can cannulate the graft itself. But if you start your reperfusion from a femoral cannula coming back, you can actually redissect up in here, and that is extraordinarily problematic. So either cannulate through the graft or through the sidearm of the graft, or if you have an axillary perfusion cannula up here, use that. By the way, if a graft that has the sidearm, at the end of the case, when you decannulate and amputate that graft, leave a big metal clip on it so that the people who do the CT scans post-op realize that that little blip that they see there is a clipped sidearm graft and not a pseudoaneurysm. Even 2 clips is better. And this just shows here the appearance of this hemiarch here, and you can do a graft-to-graft anastomosis, or sometimes if the case is moving along quickly, I won't even use a proximal graft, but just bring the arch graft down and sew it to the sinotubular junction diameter. Robin Cohen has a beautiful paper in the Annals about some of the technical nuances of these operations. And I really like this slide that just shows the importance of needle angles and using the curve of the needle, that the needle really needs to be passed perpendicular through the tissue and whatever felt there might be. But when you start going in at angles, or if you puncture the tissue and then rip the needle through it, you create these little micro tears that can become late dissections and also contribute tremendously toward bleeding. So that little thing, respecting the needle curve, puncturing the tissue perpendicular, and being gentle with these tissues is really important with these cases. I don't have a good slide to show this, but you know, if you have somebody helping you and you've just passed the needle through and that person is now following your suture, it's really important that they not pull in a way that will tear that tissue. There's a tendency for your assistant to approximate the aorta and the graft, and if they're putting tension on the stitch that's just passed through the aorta, they're tearing it. So I tend not to make the stitch very tight as I'm making it, and I make the point of that they should follow and pull the suture away from the anastomosis, not across it, because that's what tears the aorta. And after the suture is all in and before you tie it, you then go back and use a nerve hook to tighten the suture up. But again, pulling the loop away from the graft, not away from the aorta, so you don't tear it. Using bioglue is a little controversial. I always feel embarrassed, and I'm fond of saying the use of bioglue is the mark of a mediocre surgeon, and I use it all the time. Just remember, it's glutaraldehyde and albumin. That glutaraldehyde kills tissue, and if you get any of that on the recurrent nerve or the vagus or the phrenic, you've fixed the nerve. So be careful about it. And it also drips through small needle holes in the graft. Don't put it on a graft if you've got suction on your LV vent, because you can draw a drop of bioglue in. When you take the clamp off and resuscitate the heart, as I said, you do want to make sure you've got antegrade bypass perfusion. A lot of these patients still have some regurgitation, so make sure the LV is emptied and well vented. If there's RV dysfunction, consider an early empiric bypass to the right coronary artery. This is just a good rule for aortic root replacement in general. If you're sitting there staring at whether the RV is okay or not and wondering if it is, in that time, you can put a bypass graft on there and then just not have to worry about whether there's a coronary perfusion problem. So it's one of those things like putting in a balloon pump. If you're thinking about it, you probably should do it. Is you're going back on bypass too, watch these femoral artery pressures. If they're very low and the radial pressures are high, you may have a descending thoracic malperfusion issue that you've created. And this can be difficult to sort out, but it's one of the reasons sometimes to reclamp and recool down and place a stent graft into the descending aorta. When to do the arch? Well, I'll tell you, this is where it really gets complicated, and I'm very conservative. I've really only done very few arch replacements in acute type A's, and I would say the time to do an arch is if there's extensive intimal tears in the arch, or if there's cerebral malperfusion, or if the arch is already severely dilated, and you just know you're going to be back very soon, or you're going to have bleeding problems with it. But most of these patients don't need arch replacements. And even, and maybe I shouldn't say this, it sounds heretical, but a small tear in the distal part of the arch, to me, that's a lot like a type B. And I don't think that's a reason you're committed to replacing the arch. Replacing the arch, unless you're doing it on a regular basis or have a lot of experience, is a big operation. And if this is your first day, call for help. Remember, this is an operation with at least a 20% mortality. The rate is almost double that if the patient's over than 75. So don't be afraid to call for help on any dissection. I'm 68 years old. I've been doing it for a while. I will still call people and for help if I run into difficult problems with dissections. It's a very high stakes, high risk endeavor. When to replace the root, I've really already covered this, but I did want to point out that if you do have tears and it's just the non-coronary sinus, you can replace that sinus with your graft and not have to replace the other sinuses and reimplant the coronary arteries. And if you have a patient with a normal valve and he's young and the patient has not had malperfusion, things are going really well, and if you're very, very good with valve sparing roots and have some experience, it's very reasonable to do that, to do a valve sparing root. Ed Chen at Emory has had a very good experience with it, but he's quite experienced. I've saved very few valves in acute dissections in my career. Malperfusion is still the problem that plagues most of us, and it accounts for most of the deaths that occur in the current era. It's between 10 and 30% that have some degree of malperfusion, more radiographic than clinical. But it is often an issue that you're presented with. In fact, I think surgery for type A's has gotten good enough that most people, the determinants of survival for the patient have more to do on how the patient arrives in your hospital. And those who present with advanced malperfusion and organ ischemia are not likely going to do well. We looked at our series at Hopkins on the various sites of malperfusion and what the outcomes were, how often they were resolved just by a proximal operation. And it's interesting, cerebral and renal actually, the majority of them recovered. But if they have gut ischemia, none of them did. Numbers are small, but the mortality was 100% with intestinal ischemia. People rarely died from extremity ischemia. But keep this in mind. And there may be some situations where you can mitigate the preoperative malperfusion by catheter fenestrations. I won't go into this, there's just not enough time. But I think this is where we need to make progress in mitigation of malperfusion. Think for a minute, though, how often leg ischemia is part of that malperfusion, and how often we just kind of put a cannula in, go ahead and do the operation and then deal with it, but then we find out the leg is swollen and ischemic. We know from the ECMO experience now that a small perfusion catheter in the femoral artery just beyond your cannulation site will keep that leg alive or give you a head start on reversing the ischemia rather than adding to it with 4 or 5 hours of more ischemia. So think about that. You can perfuse the leg off the heart-lung machine while you're doing the central repair. There are situations where the effort is futile. Patients in their 90s, patients who are extremely frail, patients who either have a stroke at presentation or may have had a severe one before. And frankly, anybody with severe gut ischemia and marked acidosis, these are nearly futile efforts. And whether the futility is being addressed before the decision to go to the operating room or afterwards, just recognize these are really important considerations. This is the one non-surgical slide, and this really made an impression on me. This is the group at St. Louis, Washington University, led by Mark Moon. He looked at the control of blood pressure after a dissection, after a type A dissection repair, and how it affected survival. And if their blood pressure was systolic over 140 versus under 120, look at the difference at freedom from reoperation. 80% freedom from reoperation if they've got their blood pressure nice and low, only about 30% freedom from reoperation if they remain hypertensive. It is really important to control blood pressure after these operations. And that, although I think all of us or most of us have to relegate this to our cardiologists, it's something we need to keep an eye on because it has a huge impact on the late results of our surgery. No real comment on this slide, but of course, as you know, Dr. DeBakey suffered a type A dissection. He had it operated on by one of his younger trainees. That's Dr. Noon back there. He was 75 years old when Dr. DeBakey was in his mid-90s. But Dr. DeBakey did survive and was able to come to a meeting and patch up his relationship with Dr. Cooley after that. So in conclusion, type A dissection is a surgical emergency with a very poor outlook if untreated. And the real world operative mortality remains at about 20% and has remained that way over the last 20 years. Careful operative planning and expeditious care are the key. Recognition and treatment of malperfusion is critical. And this is an operation where attention to technical detail pays tremendous dividends. And finally, long-term blood pressure control and surveillance imaging are important to survival. Finally, I will say that perhaps more than most other cardiac operations, this is really a team effort. And your greatest asset in the operating room is your team. Respect them, appreciate them, and use their expertise and strengths. Your patients will benefit and they will thank you. Thank you very much.
Duke, thank you very much indeed. Like I say, I wish I'd had that talk before I was a first aid consultant. There's quite a lot of questions coming in on the chat. I think we'll spend a few minutes maybe trying to address some of these. One of the messages that I've got from you, that I got from one of my trainers, Alan Bryan, is better a living problem than a dead certainty. So I use that phrase because there's a lot of people asking, you know, should we be doing an arch in everybody with a dissection? Should we be trying to improve the long-term results? What is our focus here? And it seems to me that like me, your focus is on a survivor. Let's take someone who's at catastrophic risk of dying and try and get them out of hospital alive and without a stroke. And then we can deal with things. So what's your stance on this? You know, well, you know, we should be pushing the boundaries, doing an arch replacement, improving the long-term outcomes. Where do you see that argument for a first aid consultant?
Well, I think you've already articulated it beautifully, and I know from your discussions and my discussions in a number of venues that you and I feel very much the same way here. I stated it another way: you can't have a long-term survivor without a short-term survivor, and reoperative arch surgery in a specialized center is actually not high-risk surgery. So if they have to come back in 5 to 10 years and need an additional intervention, I still would call that a victory. So yeah. Yes, I agree. I think you deal with the most pressing, life-threatening issue. That's part of why I stress the 20% mortality issue here. We don't need to push that upward to prevent a problem that you don't even know is going to exist. And most patients do not need surgery later on.
Yeah. Okay. Debs, any comments on that from the Liverpool group? And I know we've got George in here as well from Birmingham. Any comments on your strategy with this? I know you're working in dedicated aortic centers, but for the guy that's out in the periphery in Alabama who's going to do 4 cases a year, what's your advice to him?
I would agree with that strategy for the new consultant and in the majority of cases. I mean, we do some frozen elephant trunks in young patients, specifically if you know they've got an aortopathy. But generally, I wouldn't do that unless they had a tear in the arch. I can think of one patient I did do an arch placement on recently. He was a young man who'd had thoracoabdominal surgery in his 30s actually, and he came in with a dissection, and I did do an arch. But again, I think it has to be considered carefully, and it depends on your experience. So generally, I would go with what you've previously said.
Okay, fantastic.
Malcolm?
Yes, George.
Hi.
Lovely to see you.
It's good to see you too. I think I agree with everything that you have said. For the first year consultant recently appointed, what he needs to aim for is to get that patient off the table alive. If the dissection doesn't involve the aortic root and it extends into the arch and the descending, an interposition graft is just enough to get that patient off the table, and that's what should be doing. And that's what I teach as well. If the root is compromised, then a ventral procedure and replacement of the ascending aorta, probably with an open anastomosis. That would be my advice. But they shouldn't go into the arch and try to do any fancy operations, because those ones increase mortality and increase complications. So there's no need for that.
Yeah, okay. So there's one more question in the chat that we'll address, and then we'll get onto the cases. But this is really, if I can paraphrase it, it's basically saying, you know, can we avoid circulatory arrest? No hemiarch, no open distal anastomosis. What about just, you know, clamping the aorta, staying in your comfort zone, and not putting everybody through the trauma of a circulatory arrest period? Before I ask you three, my teaching on that is sort of twofold. One is that circulatory arrest is actually not that threatening, and we've got adjuncts now that are very, very easy. And there may be definitely certain cases where that's a strategy, like Duke's alluded to. But I was always taught that if you do that, you're leaving behind a clamped part of the aorta, which is already weakened, that you've clamped, and they may run into problems in the future. So what are your thoughts? I'll start with Duke, and then I'll go to George, then I'll go to Debbie, of just adopting this strategy of, you know, no circ arrest, just clamp the aorta, do a little interposition graft, and then get out of there.
Well, I agree. With you. I don't like clamping a diseased, dissected aorta and then leaving that tissue in there. It's insult to injury, and I think that a short period of circulatory arrest is fairly benign, and I think it's good to have a good view of the inside of the arch briefly. It's important to stress that the difference between circ arrest and with, you know, somatic circulatory arrest with antegrade cerebral perfusion versus cooling to 20 degrees and shutting the whole pump off and taking the clamp off. I think in general, I like the idea of the selective antegrade cerebral perfusion, so that you have a little more time in case it turns out that the arch work is a little more complicated than you thought. If you're just starting out, that safety net of some antegrade cerebral perfusion is I think a good idea. Yeah,
no, I agree with you. And I think the thing that we've maybe missed over the years is how easy it is to do.
Yes.
It's just, you know, 2 little pipes in some holes, or 3 little pipes, however you want to do it. It's very easy to do. And certainly I agree with you that we've introduced that routinely. And when we're training people to do dissections, it gives us a big comfort zone in terms of time. So I think that from your opinion, my message would be to the people asking that question is learn how to do this very quickly, very safely, very efficiently, and you'll give yourself more time. So don't panic. You've got an extra armamentarium there. George, any thoughts on that?
No, I fully agree with what have been said. I think that doing the distal anastomosis with the clamp open is much, much easier than doing it with the clamp on. The other thing is that the clamp in itself deforms the aorta, and as you stitch, you're tractioning all those tissues and tearing the tissues. So I will always try and advise people to do it even with a short period of circulatory arrest, but to do it with the clamp open.
Yeah, okay.
Malcolm, can I ask a question?
Sorry, who's that?
It's Aaron. Can I ask a question?
Of course you can.
So there was a question on the chat. So Debbie, you're the expert.
Go on.
Retrograde versus antegrade cerebral perfusion.
Well, so I don't use retrograde cerebral perfusion anymore, apart from in a couple of special circumstances. So we know that antegrade cerebral perfusion does perfuse the brain. We've got evidence of that, and I would use that as my dominant strategy. There are a couple of situations where, and I think it does give you more time, as the previous speakers have said. There are a couple of instances, however, where we would occasionally still use retrograde cerebral perfusion. So I think it does have a potential use in terms of flushing out debris. If you're worried because of atheroma or a really dissected arch vessel, and you don't want to put a pipe up it, then I think that's fair enough. I think that's reasonable. And I sometimes have not cannulated the left carotid because of that. And the other reason, there was one case I did where the arch was, it was a high risk patient with an extremely atheromatous arch, and I just did not want to cannulate the head and neck vessels, so I did use retrograde cerebral perfusion. So occasionally I will still do that, but generally speaking, I will go for antegrade cerebral perfusion. And I completely agree with what the other speakers have said. I think with circulatory arrest is your friend in this situation. You can do a nice tension-free anastomosis. You've got lovely visibility, and top tip, always have an extra sucker. So always use 2 pump suckers and put one down into the arch, and then you'll have good visibility.
And 1 or 2 vessels for antegrade perfusion.
So generally I would use 2, but apart from these specific times when I'm worried about cannulating the left carotid, and often I'll do axillary cannulation. So you all you need to do is snare the innominate. You don't actually need to stick a pipe up there because you've already got your axillary. And if I am doing a total arch, often I will also perfuse the left subclavian, because if you're going to be a long time with your circ arrest period, I think there's some evidence that you perfuse the posterior, the back of the brain, basically better if you perfuse the left subclavian as well.
Okay, so I think, Aaron, if it's okay with you, one more question, then we'll move on to the cases. And one question's come up about monitoring during circulatory arrest, specifically NIRS. So again, I think I'm just going to go through all 3. So Duke, how do you monitor cerebrally when you're on circulatory arrest with whatever sort of perfusion strategy you're using?
Well, I monitor the clock, not the not the blood saturation, not the temperature.
Okay, fantastic. George, you're a technology guru. What about you?
Yes, thanks for that. But, I mean, I work in an aortic service, and as such, we have got the whole implementation. So we will monitor with NIRS. But I agree with the Duke that probably the clock is as important probably as the NIRS.
Yeah, okay. And you, Debs, you use NIRS?
Yes, we do. Yeah. So generally I would use bilateral perfusion. Again, be as expeditious as you can, and so you can either you can perfuse the left subclavian, or you can place a cannula in there to stop steal phenomenon from it, and that can sometimes help if you find your left side dropping. But again, sometimes there's not a lot you can do about it, and you just have to get on with it.
Yeah, we use it. I find it very confusing. I don't understand the technology, but for me, to be very simple, if you can measure pressure and flow going in, that's enough for me. You can't do any better than that. So for us, the NIRS hasn't really changed anything. I'm not sure that necessarily we can react to changes in that in real time. But anyway, I've given people email addresses so we can maybe continue this conversation on email. Maybe if you agree, Aaron, we should go on to the case section of this aortic session.
Yep, go for it.
Yeah, go for it. Okay, so I have to share screen now. So if Duke could take his off. Okay. So we've got Duke and Debs and George, and I think Mark Redmond's here as well, that are going to be part of the panel for these cases. We're going to present maybe 3 or 4 cases. And in terms of what we want you to go away with after we've done this is an understanding of the principles of managing intraoperative aortic catastrophes, with a focus on the principles of organ perfusion in very complex cases, and maybe we can touch on and have some discussions about the cerebral perfusion issues that we've brought up already, and also maybe to give you an idea of how to deconstruct some very complex cases and put together a management plan, because these can be very, very complex indeed. So let's start. Is that playing for you?
Yes, it is.
It is. Okay. So let me go back. So the first case that we've put together is, I think, a case that will allow you to understand that a lot of things about aortic surgery are entirely unpredictable, and you have to be prepared for anything. So these are all real cases. Before we present them, I should say that no human was harmed in the making of this presentation. So this is a 57-year-old guy, and he comes back to us with really bad heart failure. 6 years previously, he'd had a replacement of the ascending aorta. He'd got a type A dissection with tamponade, so he'd had an emergency operation, and he'd done fine. And this is his echo. I'm going to go through these reasonably quickly. Normally in the tutorial session, I would be getting all of you guys to describe what you can see, but in the context of Zoom, you're very lucky. I'm going to do that for you. So you can see that he's obviously got pretty severe aortic regurgitation. And we often have a discussion about aortic regurgitation in post-dissection patients. And as Duke so elegantly put in his talk, some patients that need a valve resuspension, however you do it, they might well be at risk of developing aortic regurgitation in the future. Okay, so he's also got some mitral regurgitation, probably functional. And he's also got some tricuspid regurgitation, probably functional. So this is the echo report that we got on him. In terms of size, ST junction 4.5, severe AI, moderate MRTR, pulmonary hypertension, dilated atrium, good LV function. So the operative plan for him was to go and replace his aortic valve and some sort of intervention on the mitral or the tricuspid. This is the pre-op CT scan of this guy. As you know, for all reoperative cases, I think everybody would routinely do a CT scan. And we're looking mainly at, you know, what is the risk of the reoperation on this guy in terms of the proximity of the previous graft of the aorta. I think you can see on this scan that we're pretty safe. We've got a very nice space between the sternum and the previously placed graft. Little bit closer here, but again, nothing particularly worrying. And if anyone wants to butt in, Duke or George or Debbie, then feel free. So this is a picture that was taken about 20 minutes into his operation. And when we're in the seminar room, I asked people to tell me whether this would be the expected picture that you would see during the course of this man's operation. And the answer is obviously no. There's been a stenotomy performed for sure. But what else have we got in this picture? Well, I'll give you the replies of some of the previous students. Number one, there's a lot of blood on the towels. That's not really expected. Number two, there's a sump sucker here, so there must be heparin having been given. And number three, there is a retractor here, which is placed in a left anterior thoracotomy. So something catastrophic has obviously happened to this guy, even though we thought when we go back to the CT that this was a very low risk restenotomy. We've ended up in a situation where the only explanation can be that we've opened the graft. And if this ever happens to you, you will be under no delusions that you have opened the graft, because there will be blood dripping from the light. So catastrophic bleeding on re-entry. What's the plan of action for this guy? How can we turn this catastrophic situation into one which is now manageable? So these are the principles, really. When we do the tutorials, everybody very clearly, as the first part with their general surgical training, is stop the bleeding, okay? But how do we stop the bleeding in a case like this? It's not a question of putting a swab in the sternum, because that won't stop it at all. It's a question of closing the closed space that is already there. So that's really opposing the sternum very rapidly. You can have an assistant do it, or even better, as I'll show you in future clips, use towel clips. In this case, we're going to need some sort of peripheral bypass for support. So we've got to give heparin, and femoral is the most rapid. Now, we've got to prepare for circulatory arrest, because even in this case, if we institute peripheral bypass, we're not going to be able to complete the stenotomy without absolutely massive bleeding. So we've got to complete the stenotomy with circulatory arrest. So femoral bypass, we're going to cool. And if we cool, of course, particularly in this patient who we know has got aortic regurgitation, we're going to get left ventricular dilatation. So we need to put in a left anterior thoracotomy. So I want you to remember all of these steps, which we've used in an emergency situation, which when we go to the other cases, we'll start to put into the preoperative planning of the very difficult cases. So the real question with this case, I suppose, is why on earth did we get into trouble when we thought we were okay? So this is the stenotomy completed. We're now dissecting the graft off the aorta. You can see that we put some stitches in there. We've stopped the bleeding. But despite the CT scan, the graft is actually very stuck to the aorta. And our hypothesis in this case is that if you can see this area here, adjacent to where we put the buttress stitches, there may well have been a bony spur that we've pushed down when we put the sternal wires out in the previous operation. And then when we've started to do the stenotomy, that's been pushed into the aorta. So here we are freeing up the aorta. But now the most important thing is that we've completely turned this operation back to normal. So we've had a 15-minute period where we've had to be very decisive, put a series of actions into place where we can deal with the complication, but now we're back to normal. So we're on femoral bypass, we're dissecting the aorta, we've got to address the aortic valve, the mitral valve, the tricuspid valve in whatever way, but now we can get the perfusionist to rewarm, and we've turned it completely into a proximal anastomosis. And just to prove that I was not lying and that nobody's been hurt in the course of these cases, this is the end of his operation. So we wanted to show that case because I think it illustrates that you need to have in your mind a very clear strategy for dealing with very complex aortic problems, particularly in terms of restenotomy, and be able to execute them, save the patient, and turn it into a very routine operation. So Debs, George, Duke, happy to have any comments on that case before we go on to the second case. And obviously in the chat, if you can put things in the chat, then we will also address that.
Malcolm, Mark here, Mark Redmond.
Hi, Mark.
How are you? Listen, one or two things, we do enjoy that particular case that you've just shown us, and I think every year the students really enjoy discussing it. One thing that I might just add to it, and that is useful for the, say, the younger consultants starting, I think it's a good strategy to overdo the preparations before any redo aortic surgery where a patient's had a previous ascending aortic graft. And by that I mean, I don't see any harm in doing an axillary graft even before the sternotomy, which is going to avoid the issues of trying to cannulate a previously operated aorta, and also gives the opportunity, where you've just shown us there, of providing cerebral protection pretty early on, because the hairy moment in these cases, I think, is when you cool for circle rest, however you achieve that, or bypass. You do then have to stop the circulation to finish that dissection. And there is a period of time when neither the heart has received cardioplegia or the brain is currently lacking in any perfusion. And so an axillary graft is quite useful in that situation. And if you think it's a waste of time doing that, I think you save quite a lot of time not having to worry about cannulating the arch or something like that in a redo case. And I just point out, I think it's also very important, multi-stage venous cannula in the groin, when you do have to go on fast, is quite useful, particularly with vacuum assist. And that really gives very good venous drainage in these catastrophic type scenarios.
No, I agree, Mark. I think it's an interesting case because there were no really pre-op markers that would suggest that we'd have a problem. So maybe just for the audience, what I would feed back to you is what on the pre-op CT scan would make you put a subclavian graft initially? Because that would have helped us. We would have just closed the sternum, grafts on, then we can open, clamp, and we've got cerebral perfusion immediately. So what are your danger markers on the CT scan that would make you say, okay, we're going to get really set up for this guy because we feel there might be a problem?
It's for me, I've never been able to predict. I've never been right. I think I've opened ones where we got in, and then we've, for various reasons, been just maybe very lucky where I would have thought we'd have been in trouble. And in fact, we overdid it, and we were on bypass opening, as it were. So perhaps if you're going to get it wrong all the time, the safest is to be cannulated. And if you do hit the blood with the sternotomy, you have those towel clips, and you can allow yourself a lot of, or avoid a lot of futzing around, as it were. But I think it's very hard to predict. The CT scan is extremely useful. However, I cannot say that I would look at a CT and know for sure that the aorta is sufficiently far away. Because the trouble with a tube graft is, as I'm sure you've found, it can just tear by virtue of the fact that you're lifting up on one of the sternal edges. You can just tear the graft, even if it's not that close.
I think that's a really important point, maybe for some of the junior members that are in this video conference, that the grafts, like Mark says, are extremely fragile. And even when you've opened the sternum and you're dissecting the graft off to do the operation, you can very easily go into them with a pair of scissors with no force whatsoever. So again, in the words of my supervisor, treat them like an unexploded nuclear device. I think that would be the key for that. Okay, shall we go on to the second case? We've got some sorry, slight technological problem. I shall close that. Here we go. Can everyone see that okay? Just one person say yes.
Yep, we can see that.
Excellent. Okay. So I'm going to leave it in this mode because then I can use the clicker. So this is a 60-year-old guy. We'd seen him 2 years previously because he'd had an ascending aortic replacement and a hemiarch for a type A IMH with multiple arch ulcers. We probably haven't got time to go into the discussion about how we manage IMH here, but it's maybe a little bit differently than elsewhere. But this is a picture of his original operation. This is his CT scan. You can see the ulcers in the arch and the indentations. And this is a video of his first operation. And I only show this because it doesn't bear a lot of relevance to the case. But for the more junior people, you can see that this graft for a hemi is severely beveled, right? So actually the definition of a hemiarch is that you replace all of the underside of the aorta. So by definition, you have to have part of the proximal descending aorta involved in the anastomosis. And I think we use the term hemiarch a little bit loosely. Everybody says, oh, I did a hemiarch for a type A. You didn't. You did a replacement of the ascending aorta. This is a much more extensive operation, and that's what he got. And these were the ulcers in his aorta. So we've got a 6-year-old guy with this aortic pathology. That's not good, but we operated on him and he did okay. And then he came back and he's got shortness of breath and he's got stridor, which is very worrying. I'm sure everybody agrees. And then when we put him in the CT scanner, this is what we get. So again, we can't unfortunately get the guys to go through the descriptive things, but you can see here, if you look at this scan, if you say to yourself normal or abnormal, it's abnormal. Good, bad or ugly, this is really ugly. I mean, this is some catastrophe that's happened in this guy's aorta with the previous graft. You can see there's a huge extension of the aorta beyond the confines of the sternum. The aortic root also seems to have a problem. And again, when we look at the lateral view, there is just this huge amorphous aneurysmal mess where there should be a very straightforward interposition graft. So if we look at the sagittal sections, again here we're down to the level of the sinuses, not too bad. If we start to move up a bit, we can see that there is this aneurysmal change here with close proximity to the sternum. If we go even further up, we can see that the relationship to the sternum is very close, extraordinarily close. And in a lot of these cases, I think it's very good to take the contrast off and have a little look at the relationship of this potential false aneurysm to the sternum. And you can see here that we've almost got sternal infiltration. And you can also understand why the guy's got stridor, because whatever's going on in here in terms of a graft dehiscence and false aneurysm has completely shifted his trachea, which is almost slit-like. I think that confirms the impression that we've had before. We don't need to go into the echo too much. Okay, so this guy obviously needs an operation, right? So the question is, what is the surgical strategy for this operation? So in terms of learning points, what I would say is, let's get back to what we did in an emergency situation for the first operation, and then turn it into a strategy for an elective operation in this guy, who I think everybody would agree, we have no chance of opening his sternum again without some sort of support. And I think our view was that even with bypass support, we're going to be straight into this aneurysm, this problem with this guy. So we're going to need to reintroduce all of the things that we had in the emergency situation and use it in the elective situation. So we're going to say to ourselves, okay, we can't open this sternum safely. We're going to be into the aneurysm. If we're into the aneurysm, There is no cerebral protection, there's no myocardial protection, there's no distal organ protection. So we're going to need to manage that. How do we manage that? Well, initially we can manage that with temperature. We can use circulatory arrest as our initial organ strategy. But if we do that with peripheral bypass, we're going to need some of the adjuncts that we've discussed before. So if we're going to cool to 18 degrees C, we're going to get left ventricular dilatation. So we're going to need to put a vent in. And we're going to need to have a strategy of, once we've done the stenotomy, how are we going to instigate cerebral perfusion? Again, we can talk about this a little bit in the discussion. We can talk about the advantages of subclavian cannulation or other methods, but I think our view in this case is that we're going to be right in the middle of this aneurysm. So why not prepare antegrade cerebral perfusion that's been mentioned before, because we'll be able to institute that very quickly and very directly. So this is this guy's operation. This is his sternotomy. So we've done the sternotomy under circulatory arrest at 18 degrees C, because we don't know how long it's going to take us before we can reinstitute antegrade cerebral perfusion. Here's the picture here. This is not the retractor that's made that hole. That really replicates the CT findings. So you can see that the sternum's been eroded by this aneurysm. This is right into the aorta. So we were right. We had no chance of opening this sternum without a catastrophic effect. And here you can see the proximal part of the graft. It's almost intersuscepted into a false aneurysm in this case. And again, this is just a picture that confirms that and the erosion of the sternum. So sternum open, 18 degrees C, circulatory arrest, then priorities. What are our priorities? Well, perfusion to the brain, perfusion to the heart, distal circulation, perfusion to the brain very easily. Antegrade cannula can be put straight in because we're in the middle of the aneurysm. And so this exemplifies that. And in terms of before, we've changed a little bit now in that we would put a perfusion cannula in the subclavian, but in this case we put an occlusion cannula just so we can put perfusion pressure. But one of my trainees actually said to me, if you're going to go to the effort of putting a cannula in the subclavian, why not put a perfusion cannula rather than an inclusion cannula? And I sort of went along with that. That's fine. So here's his operation. So here's the route. So now we're in a situation where we've got antegrade cerebral perfusion. We've got myocardial protection because we can give cardioplegia. So now we've got to think about our distal organ protection. We're at 18 degrees C, so we've got a period of time. But the way that we strategize the operation will allow us to restore perfusion to the distal organ bed as promptly as possible. So we're going to do a distal first anastomosis. And in a case like this, just one little tip is that the anastomotic site is often a very long way away in these redos. You can't just mobilize up the aorta and encircle it like you usually do. So in this case, we've taken a Sienna graft, which I'm sure you know has got this little cuff on it, and we can implant that in a parachute fashion. So we don't actually have to be stitching in our usual manner in such a far distal anastomosis. When that's in, then we've got antegrade cerebral perfusion still going. We're going to reimplant the head and neck vessels. But before we do that, we can reinstitute antegrade cerebral perfusion. And here the head and neck vessels have been reimplanted. So distal first, distal vessels are reperfused, implant the head and neck vessels, antegrade perfusion restored, and then we can deal with the proximal route. And so this is the final article for the guy, and this is his follow-up CT scan. So you can see how far away his distal anastomosis was. So I think the point of this case is very complicated case. Again, going through the risk assessment of what do I need before I can open the sternum safely in this guy. There's absolutely no way that I can do it in conventional fashion. Can't do it with just bypass support. So now we need to bring in our armamentarium about how we're going to organize organ protection for this guy. Phase 1, 18 degrees C, circulatory arrest. We know from the admittedly hamster studies that we've got 30 odd minutes before we get into trouble, but we know that we're going to be in the aneurysm. So then priorities once we're in: antegrade cerebral perfusion, myocardial protection, distal anastomosis first, distal perfusion, cerebral vessels reattached, cerebral perfusion, and then the proximal arch. So I haven't seen the chat because I'm still on the screen sharing. So if anybody...
Okay, so you've got a question, Malcolm. So Mark, can I ask you, because you do lots of pediatric surgery, a membrane on the sternum of the first surgery when you expect to go back in?
I can't say I use membrane in every aortic case, but there is one end product that does worry me, and we do use a membrane, and that is occasionally, despite my best efforts, the grafts, say I'm joining an arch graft to the root graft, as it were, and you can occasionally get those a little bit long. And if they are, I always worry that that would be pushed up against the sternum. So in those situations where I haven't got the aorta as perfect as nature would have it, I would cover those with a Gore-Tex membrane. In the habit of doing that. In pediatric surgery, yes, we do use it. We don't use it all the time, but in certain cases, yes, it definitely helps, particularly when there's little or no pericardium left, because we've used it obviously for some repair or other. But in the adult setting, in aortic surgery, particularly even this, when we cut grafts as short as possible, and we can still have a graft that's a little long and therefore tends to abut the sternum. And I think it's worth covering it in that situation.
George, any comments?
Yes, the more I've been doing aortic surgery, the more scared I am that the graft will get stuck to the sternum or the development of pseudoaneurysms. And therefore, in young patients, especially, preventing or being ahead of the re-intervention, I always cover the graft either with mediastinal tissue or, like Mark was saying, with Gore-Tex patch.
And Duke?
Yeah, I use the Gore-Tex patches when the graft is fairly close to the aorta. They do help. It's still possible to saw through it, but you at least have a chance at it. I think Mark's point about the changes in the graft size over time is really important. I mean, Randy Greek did studies years ago that showed that most Dacron grafts will dilate over time, somewhere between 10 and in some grafts even as much as 20%. It's very manufacturer dependent. But not only do they dilate, they elongate, and it's just a good general principle in aortic surgery, particularly since they have corrugations that allow them to fold or bend without folding, that you really have to stretch grafts, and you don't want them under too much tension, but if you don't stretch it out a little bit and put it under a little bit of tension, it will elongate and change its course, just like Mark said.
Aaron, I think that's really interesting about, should we have some sort of protective measure? Obviously, I've picked cases where probably that would make no change whatsoever, because the aneurysms are so extreme that it's not going to have an impact for you. But I think it's something to think about. And I think Duke's comment is very astute. And that is, when you go back to the first case, you think you've got a very low risk case. But actually, these grafts do change over time, and we've seen that. And I think one of the messages is, do not underestimate reoperating on somebody who's got an aortic graft in place. Whatever your CT scan shows, whatever you think, do not underestimate that operation. Okay, so should we go on to the third case?
You just got one question, Malcolm, in relation to that actual case on the chat.
Okay.
Have you seen it? Can you see it?
Do you do the or dissect? Oh, okay. So what I was meaning in that operation is that your distal anastomosis is a long way away from you. Okay. So normally, if you're doing a first-time arch, you can almost encircle the proximal descending aorta and do an over and over anastomosis as normal. In the redo situation, it's not possible to do that a lot of the time. So what we do is we take the Sienna graft with the cuff, and then we can implant it like you do a root replacement. So you can put interrupted buttress sutures, and then you can put it down a long way away from where you can actually stitch. So I think that's one of our techniques for dealing with that problem. In these redo cases, your anatomy is often so distorted that you haven't got your normal comfort zones like you normally do. I hope that answered the question. Okay. Everyone see this? Just one yes?
Yes.
Thank you, Mark. Okay, well, you know these cases, Mark. I know we've been through hours of turmoil with these cases. So this is again, it's a complicated case, but really what we wanted you to do is to think about your strategies of organ protection once you've done a complex restenotomy. And that might be very different case by case. And so I've picked a different case here that will require or mediates itself to a completely different approach for restoring cerebral perfusion, distal organ perfusion once you've done the restenotomy. So this is a 65-year-old guy. We've had one go at him for an aortic valve for endocarditis. And then he came back a year later with recurrent endocarditis, and he had a Bentel operation. And now he comes back short of breath. And this is not the sort of echo that you want to see at 8 o'clock on a Friday. Again, I can't ask you to describe the abnormalities, but when we look at echoes of a root replacement here, one of the things that I look for is stability. Okay, and this is moving a lot. I think you can all see this is moving a lot. So that's not good. Okay, so if we go through the echoes, I'll skip that one. So here's the site of the previous Bentel. You can see the prosthetic circle here. You can see the annulus that it's supposed to be attached to here. There's a space between the two. That's not good. If you look at the area of the aortic valve leaflets, you can see that there are some things moving around. There's some movement here at all. So quite often when we do the tutorials, I always say, you know, good, bad, or ugly, normal or abnormal, abnormal, good, bad, or ugly, that's ugly. Okay, that's not good. Another view, and again, you can see a lot of movement here where the root replacement should be fixated. So we know we're in a lot of problems. And this is the echo that's going to tell you everything that's wrong with this guy before we even get to the CT scan. So let me talk you through that. So this is the plane of the previous Bentel. So this is the plane of his mechanical valve. The white that you see here are the edges of his ascending aortic graft, the integral. And what you can see is that this part of the graft is being so pressurized by something from the outside that it's, in Sicily, it's coming across and it's almost causing left ventricular outfront tract obstruction. So we know from this echo and the previous echo that this guy must not only have an infection, vegetation on his valve and some sort of dehiscence, but he must have a false aneurysm, which is being preferentially perfused on the outside, so that the pressure in the false aneurysm is greater than the pressure that's being generated by left ventricular systole. So this is a big problem, and we've identified the shunt there. So if we go to a CT scan, and again in the tutorials I normally ask people about the anatomy, a lot of the answers we get back is that this must be the innominate vein, because anatomically it seems to be in the right place. But if you look closely, obviously it's in the same arterial phase as the ascending aorta or the previous graft. So this must be something that's being perfused in the arterial phase of the cardiac cycle outside of the aorta. And when you fix that with our previous echo, you realize this guy must have an infected false aneurysm, which is outside of the aorta. And as we go through the CT scans, again, looking at the proximity according to the sternum, that's pretty close. And this very disjointed aneurysm here is absolutely abutting the sternum. I think I've put some videos here just for my vitriol. This was his second operation when we did the aortic root replacement for his endocarditis. And again, I'm going to, in the interest of time, go through these reasonably quickly. But it's one point to make is that when you're doing reoperations on the root, I try and put in the biggest root I can, because you've often quite lost the annulus and you want the root not under tension. So if you undersize, it'll be under tension at risk of dehiscence. Obviously that didn't work in this case. But again, this is us just finishing his first operation. And for me to say, I did a good job first time, it's not my fault. So what are we going to do with this guy? So again, we're back to the issues that we've talked about previously. We've got sternal reentry, myocardial protection, cerebral protection, distal organ protection. So how are we going to plan an operation for this guy that's going to end up being safe? So sternal reentry. So can we get into this mediastinum safely with no adjuncts? Well, I would say from the CT scans, not. So we're going to have to do the same things that we did before. We're going to have to say we need peripheral bypass. We're going to have to say peripheral bypass will not be enough. We're going to have to say we're going to use temperature as our organ protection strategy. So we're going to use myocardial arrest. And then once we've opened the sternum, we're going to need to have a strategy for cerebral and myocardial protection and distal organ protection. And I'm going to go through the case because I think this emphasizes quite nicely how each case is very individualized, and what you do depends upon the situation that you find yourself in. So this is this guy. So we're all set. We're on peripheral bypass. We've got a left ventricular vent in as normal. One tip is that always put some opsite over the left ventricular vent site, because otherwise through the thoracotomy blood will drip out, and there's nothing more depressing than having to change your socks before you go home. And this is his operation. So we're fem-fem bypass, LV vent, circulatory arrest. We've opened the sternum and we're now doing a little bit of the dissection. But think about this case, different to the last case. We don't need to do anything to the aortic arch in this case. His problem is proximal, totally proximal. So in terms of our organ protection, myocardial, cerebral, distal organ protection, what is our priority once we've done a stenotomy? Well, if you look here, the priority was very easy. If we clamp the graft, we just need to put a clamp on the graft, and then we can say to the perfusionist, you can restart the circulation. Then we've got distal organ circulation, we've got cerebral circulation, and we can concentrate on the proximal problem. And I'm afraid the bandwidth is making this a little bit jerky. But we're dissecting out now for myocardial protection. And the time of this video, from when I started it to when we managed to get direct coronary cannulation, is about 2 minutes, 30 seconds. So with a very well-planned strategy of once we're in there, we're going to clamp this graft. restart the circulation, protect the brain, protect the distal organ bed, then dissect out the coronaries, we've got a good organ protection strategy for this guy. And the other points from this case that I think that we wanted to make is the concept of pressure points in an operation. So this is, he's had a previous route, we've just cut it out. We've got all of the issues that we've got to deal with of reconstructing some sort of an aortic annulus, putting it all together so that we can put a root back in. But what's the real pressure point in this guy? A reoperative root replacement. Well, the real pressure point, as we know, is the coronary arteries, isn't it? They're very difficult to mobilize up. So we need a strategy to deal with that. And this is very well publicized as a Cabral graft, excuse me. So this is the left coronary. We're just testing it now to make sure it's hemostatic. If you look in the books, the historical Cabral graft was a single graft from the left coronary, then anastomosed onto your aortic graft, and then anastomosed to the right coronary. And we've never done it that way because I think that that puts you at a disadvantage for sorting out bleeding because it fixes your graft in 3 areas. So it's very difficult to manipulate that graft and see if you've got any bleeding and where it's coming from. So we do a separate graft to the right coronary. And again, I think you can see here with the thickness of the right coronary, this would be a very difficult coronary artery to mobilize up to do a normal root replacement. Again, I'm not going to go into this too much, but you saw the annulus before, completely destroyed. So we've used a pericardial patch to try and reinforce the annulus. We don't want the same problem again. And these are the 2 Cabral grafts in place. We're going to use the right one, as I'll show you, as a very short interposition graft, because I think that's the easiest way of doing it. But in terms of so this is the right graft being sewn on, short interposition graft, no real problem, easy access for any problems with bleeding. But for the left Cabral graft, we do bring it around the curve of the aorta, because I think if you leave the left Cabral graft as an interposition graft, you can end up, once the sinuses and the Valsalva graft are filled, having pressure on it. So we'll bring it around as a curved graft. And again, in the interest of time, I won't show you all of this, but you do the completion ascending aortic anastomosis and then put your Cabral graft on. And then in the follow-up CT scan, what you can see here is the graft going to the left coronary lying nicely behind the ascending aorta. So the point of this case is similar scenario, high-risk sternal re-entry, but completely different tactic once you're in there in terms of how you've adjusted your priority for organ protection. And in this case, rather than thinking about having to introduce antegrade cerebral perfusion or some of the complicated techniques that we have, you can simply just put a clamp across the graft and you've turned this into a proximal operation with good distal organ perfusion, good cerebral perfusion, and your standard myocardial protection. So happy to take any questions on that case.
So there is a question on the chat. So can I address this to you, Duke? So do you think there's a role for routine pre-op CT head to assess the circle of Willis in aortic surgery?
I think that's a very good question. I don't know if it needs to be routine. You know, there are certain operations that might involve interruption of the circulation or an extended period of antegrade perfusion. But my feeling was that if you cool the brain down on bypass before you change to selective cerebral perfusion, and then once you've reached that very low temperature, use unilateral perfusion, I think you have enough enough time, even with an incomplete circle of Willis, to probably get everything done. Although I could imagine if you really had an hour and a half time or 2 hours, that might be not enough, and that then you should go with bilateral, cerebral perfusion, antegrade. So that's not a satisfactory answer. I think I would do it only if I thought that it was a very complicated arch reconstruction where I might need an extraordinarily long period of time of antegrade cerebral perfusion. It might be nice to know ahead of time if I really needed to do bilateral carotid perfusion.
And screening for aortopathies?
I think that's a good question too. We haven't usually done it, but I could imagine a situation where knowing about a specific mutation might lead to a more aggressive resection. But it's not been my practice. I think the genetic underpinnings to all of this disease, it's still very much in its infancy of our understanding. So I probably wouldn't, because I wouldn't know, in most situations, I wouldn't know what to do with the information.
Debbie, do you do any of that?
So we've started to screen do a CT to assess the circle of Willis in patients, again, similar to Duke, really, I suppose, if we think they're going to have a complex arch replacement. So if we think it's going to be a difficult total arch, then we've started to do some more screening. In terms of screening for intracranial aneurysm, we have picked up a few actually recently. We had a patient, very sadly, who died after a dissection, a young woman who turned out to have Loeys-Dietz, but she died of a subarach hemorrhage some weeks after her operation, after having had rupture of an intracranial aneurysm. So since then, we've kind of we have started to screen more people. So certainly the ones who have an identified genetic mutation, such as the Loeys-Dietz patients, we do screen those for intracranial aneurysm. And then if we have a family history of intracranial aneurysm, we would screen them as well. So we have started to do some more.
You got time for one more case, Malcolm? Sorry, Mark, did you have a comment?
I was just going to comment on genetics. Like Duke correctly pointed out, it's in its infancy, as it were, with regard to tailoring an operation for a given patient. However, there is the ACTA2 mutation, which is important in that in younger patients, they're at risk of type B dissections, and even more so than type A's with a given aortic, an ascending aortic size. And I think pretty soon we could justify, were we to be intervening for the ascending aorta in a patient with an ACTA2, that we could consider, say, a frozen elephant trunk or a more extensive operation to eliminate the distinct possibility of a type B dissection in these patients, because there is some evidence that putting a stiff aortic roof replacement graft increases the risk of a type B dissection in Marfan syndrome. So you could make that argument when it comes to ACTA2 mutations, where younger patients are more at risk of a type B rather than a type A dissection.
You know, Mark, I understand your point, but you could make the counter argument that putting prophylactic frozen elephant trunks in these young patients is using stent grafts in the patients for whom stent grafts generally don't work well at all, and that you might be creating another problem too. But I do take your point about the ACTAs, and the Loeys-Dietz are the same way, and Marfan, frankly, although usually you have that diagnosis because of their phenotype, but the minute you replace the proximal aorta in either of those two patient groups, their new threat to their long-term survival is a type B dissection. And this is actually where I think that the pairs approach might actually offer some opportunity there, because all of these dissections get started just beyond the left subclavian. You could imagine if you had a pairs patch, you could just wrap the distal, the aorta just beyond the left subclavian and stabilize it, that you might prevent some of these late Bs. I'd love the opportunity to put patches or encircling patches on that part of the aorta to see if it prevents type Bs.
Duke, I would agree. I think that would be even perhaps a more important use of the pairs graft, personally, because the valve-sparing route has its role, and we put some pairs on it in Dublin, often in the setting of Marfan patients who require another operation, such as mitral valve. However, we are just for whatever it's worth, and we are doing it in pigs at the moment, trying to wrap their arch. The problem, of course, is that if you put it beyond the left subclavian, which of course is easy, would you encourage a retrograde dissection? However, it will be interesting to see how that develops.
Okay, Malcolm, you've got 5 minutes. Educate us.
You want one more case? Yeah, Birmingham.
Always one more.
Blood out of a stone. Right. Okay. So I always say every year, this is a present to you. This is something that is very well known, but I think it's something that we don't utilize enough in aortic surgery, and I think it's something that can really get you out of some very big problems. And what is the biggest problem that everybody worries about doing aortic surgery? Bleeding. So arch, not a big problem. You can pack it really hard, great. Proximal aorta, not so easy, because you've got the coronaries there, you pack hard, you can get compression. So I'm going to talk you through a case and give you a potential solution that maybe for some of the younger guys, in 20 years' time, you'll be in theatre in the middle of the night, you'll have a problem and you'll think, oh, I remember when that idiot from Hong Kong told us about this, and you'll bring it into action, which is exactly what happened to me, because it wasn't an idiot, but it was a Brazilian surgeon that really introduced this to me. So I'm going to go through this quite quickly. 42-year-old lady, she comes with short of breath. She's previously been treated in China. Okay, so the bad news is she's young, all right? The more bad news is her history. So in 2006, she had a mechanical aortic and mitral valve replacement for endocarditis. She had a reoperation 2 months later for endocarditis with a redo double valve. And then 2 years later, she had a third time redo for dehisced valves. They thought she might have Behçet's disease, treated her with steroids, but that was never proven. She came to us in 2011 and she got pannus obstruction of both valves. So we operated on her for a fourth time, replaced the aortic and the mitral valves, and did a tricuspid annuloplasty. And we were so pleased that we took a lot of pictures during the course of this operation. They were using single disc valves at the time. So here you can see the pannus around the valve. This is the aortic valve, and these are the valves that we took out of her. And again, just for my complicity, this was the echo that we left her with. Very good, normal echo. Uneventful recovery. She comes back to us 9 months later. Urgent admission, shortness of breath, heart failure, on the high dependency unit, not requiring intubation, but not far off. So this is all turning out to be a bad scenario. She's young, multiple reoperations, and now she's in a real clinical problem. And when we look at the echo, again, you know, I'm sorry we can't go through this in a lot of detail, but if we look at the aortic valve here, just an extraordinary amount of movement. That's just not normal. So when you look at echoes sometimes, rather than getting fixated in terms of identifying abnormalities, just think normal or abnormal. That's abnormal. Okay. Other echo pictures confirm that. So she's got a massive aortic valve dehiscence here. And if we look at the mitral, it's exactly the same. Huge movement of the mitral, massive regurgitation. And again, confirmed on this echo. And a real problem here, we're suspecting with the aortomitral curtain, because once you see these patients who've had multiple double valve reoperations, there's often a complete separation between the aortic annulus and the mitral annulus. So what do we do? I'm not expecting any replies from this, but you know, the questions are, do we have to operate on her? Yes, we do. She's young, and if we don't operate on her, she's going to die. So we go through the surgical strategy. So she's not a problem for sternal reentry like the problems that we've talked about before. We might want to introduce peripheral bypass. We think about venting, myocardial protection, or surgical strategy, but she's a different problem because she's a proximal root problem. So very conventional stenotomy, but when we operate on her, it's obvious that she's got a complete dissociation between the aortic valve and the mitral valve. She's completely lost her aortic valve annulus. So we've come up with a surgical strategy, and again, just for the interest of time, we don't need to go through it all, where we've managed to put some patches in, we've replaced the mitral valve, and now we're reconstituting the aortic annulus. But as you can see, this is very deep. There is no aortic annulus to speak of in these cases, and often you're improvising. So she had a mitral valve replacement. Before that, we'd done a patch down through the non-coronary sinus, a root replacement with a Valsalva, direct coronary reimplantation, because opposed to the root replacements before, this wasn't a reoperation on the coronary, so that was fine. When we come off bypass, we've got big bleeding from the aortic root. I mean, big bleeding. So tactics for bleeding proximal aortic surgery. Well, I'm sure you know all the first 3 Ps, protamine, platelets, packing. Sure, we all do that. I add patience. You need a lot of patience. Shibrim Al-Khoury taught me pipe. He used to say, there's no bleeding that won't stop if you go away and smoke a pipe for 20 minutes. I haven't got a pipe, so that's not an option. So what I'm going to introduce into this equation is patch. And this is very well known, but very underutilized. So this is that patient. So we've had massive bleeding, not controlled with protamine, platelets, packing, didn't do a pipe, did a lot of patients. So how can we solve this? How can we turn this uncontrollable bleeding situation into a manageable problem? So this is a modified Cabral patch. So the idea is that you take a pericardial patch and you sew it through the PA, the outflow tract, back down onto the SVC. So you enclose the aorta, because obviously in a redo, the transverse sinus is shut anyway. I know some people do, but I don't like to do that. Some people then just leave that as a patch. But I think that that can compress the coronary arteries if you get bleeding into that patch. So I like to take a little shunt, which normally goes into the right atrium. But in this lady, the bleeding was so bad that I was worried that there would be a left to right shunt. So I actually put it into her left atrium. And then I took her back to theatre the next day because she was packed. And then I clamped the shunt, and the patch filled, but it didn't fill as much as it did the day before. So I changed it into a right atrial shunt. Obviously, you can't leave it as a left atrial shunt because, as we'll see later on, these conduits thrombose, and you don't want her to get TIAs and strokes from this. So we've done this in a few patients now. You can do it in very complex cases, use multiple patches. Here again, you can see it going to the right atrium. This is a horrible 6th time redo catastrophe. And here you've got 3 pericardial patches that have encircling the aorta. It's been very well published. It's not my idea. It's people that have come up with it. We've modified it a bit, but you know, the idea of enclosing your graft with the aneurysm and then putting a little patch in is very commonplace. Very complex techniques where you can incorporate part of the right atrial appendage into your patch. In cases like this, where you know we've encountered this horribly calcified proximal aorta, the stitch hole bleeding from that, no matter how good a surgeon you are, it might be catastrophic. So turning it into a manageable situation might be a reasonable thing to do. And again, this is just a follow-up of some of our cases and the CT scans. But if I show you that lady's CT scan, her follow-up CT scan at 7 months after the operation, what you can see is the ascending aorta completely normal. Normal sort of thrombosis around the outside. Here's the graft, completely thrombosed. And so we've turned a catastrophic situation using a very easy and should be well-known technique into a survivor. So my message there, my final message is never give up. Thank you.
Well done, Malcolm. It's really an important lesson. Actually, Mark Redmond and I had a case, I could see him laughing, that we did together in Baltimore, did the same thing, and it worked very nicely. And I just want to add, the other P, if your patch doesn't work, is for prayer.
Yeah, that's very true. But you know, interesting story. I did that little vignette when we were doing a hospital visit in Pakistan. And it was a late evening meeting. And the next morning, one of the junior guys came to see me and he said, you know, my boss has just done a dissection. They're still in theatre. They've got terrible problems with the bleeding. I know what you said about this patch, but I don't quite understand it. Can you talk to him on the phone? So I spoke to this guy on the phone. I said, okay, this is what you do. And he did it, and he went away, he went quiet for 10 minutes, and he came back and he just said, miracle. And it's not from me, it's out there, it's in the literature, but I think it's something that in catastrophic situations, maybe we should be advocating more in aortic surgery, because it can really get you out of a lot of trouble with that proximal route.
As a modification, Duke alluded to the case that we did together many years ago. But Duke had a marvelous innovation that he didn't mention there, which was, instead of any Gore-Tex graft going from the, if you want, the pericardial patch into the right atrium, he had the idea that we would put an opening in the innominate vein. I don't know if you remember, Duke. So when we sewed the patch onto the SVC, we created an opening directly into the innominate vein so that it just drained directly into the venous system. And I thought it was a lovely modification, which did not put the patient at any risk for thromboembolism. And interestingly, that closed off on its own, as I saw on the CT on that particular patient several years later. So thanks, Duke, for getting us out of trouble that day.
I didn't remember that part at all.
Yeah, I thought it was a brilliant idea.
Well, great cases, Malcolm. Well done.
Malcolm, just time for one quick question. People want to know can you just repeat where you sew the patch?
Okay, so if you're standing in theatre and you look at the ascending aorta, it's surrounded by pulmonary artery, right ventricular outflow tract, SVC, and then up onto the innominate vein. And normally in a redo, the innominate vein area has got a lot of adhesions, quite fibrotic. So what you basically do is just put a cap on the aorta. So you sew it to pulmonary artery, right ventricular outflow tract, down onto the SVC, and then up onto the innominate vein or the adhesions that are by the innominate vein. The real problem occurs is when you want to do it and you have a virgin operation, i.e. you've got a transverse sinus which is open. And for those of us that went through the era where we're putting the right internal mammary artery through the transverse sinus, you know how easy that is to do. But you can still fix that problem. You can occlude that with stitches and you can put Surgicel in there. But in essence, it's the best technique for a reoperative procedure. And all you've got to think about it is, ace in the aorta, I'm going to put a hat on it and stitch it to all of those anatomical structures. And when you do it, the really interesting thing is that you come across some quite fragile tissue when you're going across the right ventricular outflow tract. But the patch itself does not necessarily have to be absolutely hemostatic, because once you've got a shunt in it, the blood will preferentially go into the right atrium. So it's a very, very easy thing to do. Promise, on my heart.
Thank you very much, gentlemen. Thank you, Malcolm, for the cases once again. Debbie, thank you very much. George, Mark, thank you. Duke, you've been a marvelous servant to the course. I think we could have used you more, but next year, maybe. And we look forward to having you all back in Birmingham. Melinda, has it? So I'd like to thank all the delegates for taking part in this. It's been a new venture for us, this virtual learning environment, and we hope that it's worked well for you. The thing that it wouldn't have worked without is actually all the people who you can't see, yes. All the people you can't see who are sitting here on our technical support team. So if I turn my computer around, hopefully you can see them all sitting there. They've been beavering away. So thank you very much to everyone who's helped. One person who always helps, Lorraine. And I think the delegates need to thank Lorraine for all the work that she's done for you guys in getting this course up and going and keeping us going in organising it. So thank you. We hope to see you in Birmingham sometime soon, and stay safe.
Thank you very much, everyone. Thanks.